We're very excited to have you all join us today. This is our first of a three-part webinar series on the virtual assessment in Lewy body dementia during the pandemic and beyond. Today's webinar will focus on the approach to clinical care via telemedicine. I'm Katie Amadeo, and I'm a neurologist and a movement disorder specialist from Westchester Medical Center in Poughkeepsie, and I will be the moderator today. And before we get started, we can go to the next slide. There's just a few housekeeping items I just want to go over. Let's see. Okay, so this is a live activity that is being recorded. This webinar will be available after today's session we'll not only be sending the slides, but it will also be available to watch on our LBDA's YouTube page, the LBDA TV, within 2 weeks of today's session. The mics of all of our attendees are muted automatically, but we encourage questions. So during the session, if you have any questions, please use our Q&A function. I will be going through those questions, and at the end of our presentation, we'll have a panelist, an expert panelist discussion where I will be asking those questions. If I don't get to your question, just due to time or something, don't worry, we'll be following up with an email after today's session. You'll keep an eye out for emails coming from Miriam that will have like a frequently asked question and also more information following this. If you're with a group, please be sure to email Miriam, and she'll provide her email with your emails of other attendees so that everyone gets an evaluation form and so forth. Okay, next slide. So today's session is brought to you by our Lewy Body Dementia Association's Research Centers of Excellence, the RCOE programs, Clinical Care and Professional Education Working Group, of which I am co-chair along with Dr. Jennifer Goldman, and we are today's course directors. If you want to learn more about the RCOE program, please visit the LBDA.org website for more information. Next slide. The activity today is supported by an educational grant from Acadia Pharmaceuticals, which we are grateful for, so thank you. Next slide. And we also, this is an accredited program. You'll be receiving an email after today's session with information on how to get CME, which there's more information on the next slide. Yeah, so physicians and allied healthcare professionals can receive one CME credit, and we'll be, like I said, following up with an email for an evaluation in order to get that. So thank you. And next slide. And these are our disclosures. So as I said, Dr. Jennifer Goldman and I are the co-directors of this course. Dr. Jennifer Goldman will be on the expert panel at the end of this discussion. And then we are very honored and happy to have two more experts with us today, Dr. Jory Flesher and Dr. Karen Martyr, who will also be presenting on the different cases today. So and they'll also be on the panel. Next slide, please. So this is the agenda for today. I just wanted to briefly go over, what we'll be talking about. I'm going to provide a brief background on what we mean by Lewy body dementia, its clinical presentation. Today, the webinar will not be focusing on pharmacologic treatment or the approach to treatment. Today's session is really to talk about the approach to evaluating, making a diagnosis, optimizing a telehealth visit in these patients. We just decided as a committee to talk about treatment would be beyond, unfortunately, the breadth of this, but please stay tuned for information or future projects on treatment. And we'll be doing today as a case-based approach. So I will present a case for the first part, and then we'll have Dr. Karen Martyr talk about how one may approach a diagnosis of Lewy body in the remote setting and how to deliver that diagnosis. And then for the second part, case 2, I'll be presenting another case that kind of highlights some challenges or limitations we may encounter as physicians or allied healthcare providers when seeing a patient with Lewy body. And Dr. Jory Flesher will be talking more about how to address those challenges. And then we will follow this, as I said, with a panel discussion with answering your questions. All right, next slide. These are our objectives for today. We really want everyone to come away. Our goal is for you to come away with a better understanding of what Lewy body dementia looks like clinically, and how to understand that it is feasible to see our patients remotely, and how to best do that, how to optimize that. And next slide. All right, so we'll start, like I said, with a background of Lewy body dementia and the call for virtual assessment during the pandemic and beyond. Next slide. All right, so when we say Lewy body dementia, what we mean by that is it's a collective term, an umbrella term that includes Parkinson's disease with dementia and dementia with Lewy bodies. This term Lewy body dementia, includes both Parkinson's disease with dementia and dementia with Lewy bodies, because once there is dementia in the setting of Parkinson's, it looks clinically very similar to dementia with Lewy bodies, but we'll talk about that more in just a bit. They're both, so Lewy body dementia as an umbrella term, collectively to mean PDD and DLB, I'll say, is characterized by dementia, the presence of dementia. It's characterized by the presence of Parkinsonism. When we say Parkinsonism, we mean slowness of movement, rest tremor, rigidity, and postural instability. There may be psychosis or visual hallucinations or delusions. And there may be fluctuations in both cognition and level of alertness and consciousness. The diagnosis of LBD requires a thorough history, cognitive assessment, and physical examination. And that kind of lends to our discussion today about how we can do that in a virtual visit. Next slide, please. So as I said, Lewy body dementia is an umbrella term to include both Parkinson's disease with dementia and dementia with Lewy bodies, which, as I said, can look clinically similar. They also share pathology. So when we think about the pathology of these diseases, what we know is that they are both neurodegenerative disorders that involve abnormal alpha-synuclein that aggregate to form Lewy bodies. And that's something that these diseases share. Next slide. Now looking at the shared characteristics, like we just said, that, like I said, they're both neurodegenerative diseases involving abnormal alpha-synuclein. They both can have premotor or prodromal, meaning before the onset of the characteristic features of these diseases, Parkinsonism, dementia. They can have these features, anosmia, so reduction in sense of smell, constipation, REM behavior disorder, acting out the dream, so in the REM stages of sleep. And these are features that we think can occur, or we know may occur 20 years or before the disease onset. So there are these premotor or prodromal features. They both share Parkinsonism. As I said, they may have the presence of Parkinsonism. They both can have the presence of cognitive and behavioral disturbances. And they both can have profound autonomic dysfunction, commonly presenting as constipation, orthostatic hypotension. Next slide, please. So, what distinguishes Parkinson's disease from dementia with Lewy bodies? Like we talked about how they're very similar, and many of us can consider them a spectrum of a disease. But when we think about how to distinguish them, it's really based on the timing of onset of Parkinsonism from the cognitive involvement and the behavioral involvement. So in Parkinson's disease, we're seeing patients, they're coming to us because of the motor features. The Parkinsonism is the initial presenting symptom. And often it's not for years, it's over time that individuals may or may not everyone will, but individuals may develop cognitive impairment that may go on to progress to dementia. Like I said, not everyone with Parkinson's will develop dementia, but when it occurs, it seems to be over time. And it's over time as the disease marches along, and as we start in the setting of dopaminergic therapy, one may develop psychosis. Now, in dementia with Lewy bodies, Dementia, by definition, it has to be there. So the cognitive impairment is the core feature, and it may present before the Parkinsonism, or if Parkinsonism presents first, the dementia is within a year. So we call that the 1-year rule. In psychosis, the visual hallucinations and delusions are often spontaneous and also present early in the course. Next slide, please. Okay, so now to talk a little bit about, I hope everybody has a better understanding of what we mean by Lewy body dementia. Now the call to telemedicine. So as we all know, in March 2020, the World Health Organization declared a pandemic attributable to COVID-19. And with this, there were orders for, to keep people safe, particularly our vulnerable population, elderly adults. Stay at home. Let's try to flatten the curve. And we know that older adults are at increased risk for complications or severe disease from COVID. And so it was particularly this call to those of us caring for elderly. We wanted to keep them safe. Lewy body dementia represents a particularly vulnerable population. When we think about the dementia, the presence of dementia, the presence of Parkinsonism, the potential to be more susceptible to delirium. And I asked you to stay tuned for that. That's our third webinar talking about COVID in the setting of LBD. And so there was this call to convert, to telemedicine to keep our patients safe. The question, was what does it look like? How do we translate care that was really largely in office for these patients to telemedicine? Next slide, please. And so while we don't have, at this time, we don't have any validating studies that validate, the care for remote care with in-office visits. But what we do have are some feasibility studies in Parkinson's disease. We really don't have that data in dementia with Lewy bodies or Lewy body dementia. So what we hope to present today is more of, us showing you how we approach this as experts so that you may be more comfortable. We are presenting some data from a survey that we administered to the LBDA RCOE centers over a 2-week period back in June. 14 of the 37 investigators responded. So just a little bit of a low response, just so everybody keeps that in mind. But it is helpful, and it did provide information about how the experts are delivering care remotely to our patients. And so, I'm hoping that will be a resource for you as well. Next slide. So we will get started now with the case-based approach to today's presentation. So I'll start, and the first part is about addressing making and delivering a diagnosis. So I'll start with the case. Next slide. So an 89-year-old man presents via televideo for a new patient evaluation in the setting of cognitive impairment and falls. That was what was bringing him to my attention. He's accompanied by his daughter, who is helpful as both an informant today to help with providing some more collateral information, but also was helpful in helping with set up the video and make today's visit, when I saw the patient, achievable. So that was good. So that's something to always keep in mind if we can have somebody help. And the history was notable for this gradually progressive change in cognition over 4 years. So what do I mean by that? What I learned was the patient over the past 4 years has had this gradual forgetfulness, where missing some bills, missing doses of medications, getting lost when driving in familiar settings. And there was also some executive dysfunction as well. So not only with trouble with driving, but trouble with being organized, planning, and so forth. And so where he was needing more help with activities. So his daughter was stepping in and helping with medications. She was doing the appointments, and this was gradual over time. And around the same time that they started to notice this change in thinking and memory, there was also this tremor, this shaking of his hands that was present at rest. Within this time, we also learned that he's become less steady with walking. His steps, his stride length is shorter, so shuffling, as they said, with rare falls, but no significant injuries or anything like that. His daughter comments that he can sleep a lot. He doesn't, he sleeps at night just fine, but during the day he just seems to also sleep, and they think he's maybe bored. He does have times where he seems less responsive. They're able to kind of get his attention, but he seems to just be zoning out or staring off at times. He seems to have this fluctuation in his alertness. Next slide. As I said, there was this rest tremor, and that's really what he was very bothered by. It's present all the time. It impacts his handwriting, eating, things like that. Learned that there's no exposure to dopamine blocking agents previously, like antipsychotics. At night, on questioning, he says he does see people or animals. He knows they're not real. So he sees people and animals that aren't really there. He knows they're not real. He says he can kind of close his eyes and then they'll run away. So he's not frightened by them. He really doesn't think much of it. He has been bothered by constipation, and he does get lightheaded when he changes position, when he stands up. His daughter comments that her mom, so his wife, has often talked about how he acts out his dreams. So he seems to be running in his sleep, and he has hit her accidentally also while acting out a dream. So there's that. Next slide. Okay, so sorry. So then in evaluating the patient, I performed a Mocha Blind, which is a modified Montreal cognitive assessment that eliminates the top portion of the exam, if you're familiar with the Mocha. So it eliminates the visual, spatial, and executive function portion. So the drawing portion, the clock drawing, the trail testing portions. And it's out of 22. A normal is anything greater than an 18 or equal to an 18. He scored a 14. He lost points across domains, notably attention, fluency, abstraction, delayed recall. So like I said, unfortunately, the Mocha Blind does not assess executive and visual spatial function. And then in terms of his neurologic exam, focusing more on the motor aspects for this presentation, there was mild hypomimia, or that reduced facial expression. There was some mild hypophonia or softer voice, no jaw tremor. There was mild to moderate bradykinesia, or that reduction in speed and amplitude with tasks like finger taps, hand opening, closing, toe and heel taps. There was a mild rare tremor, actually. So while he said it was all the time, that's the, I guess, trouble with video a little bit. I only saw it every now and then. It did emerge with posture. And then he was able to arise to standing with no assistance, but he was a little bit slow and cautious. He mentioned that he felt a little momentarily dizzy with standing up, but otherwise his gait was narrow-based and steady, but there was this reduction in his stride length and arm swing. Next slide, please. And so this is where now I'd like to pause, and we're going to talk about how we might, approach the diagnosis of this patient. And Dr. Karen Martyr will lead this discussion. Thank you.
Thank you, Katie, and I'm delighted to be here. So let's talk a little bit about the diagnostic criteria for Lewy body dementia. Can I have the next slide, please? So these are the criteria for dementia. They've been presented in the 4th consensus report of the DLB consortium, and this is in neurology in 2017. I'll go through all the criteria for you, but the main difference in this set of criteria are the importance of REM behavior disorder, which you already heard a lot about this afternoon. So that's the 4th clinical criteria that you're going to hear about. Next slide. So again, this is slightly busy, but as you've already heard from Katie, the essential criterion for DLB is dementia that occurs before or concurrently with Parkinsonism, that 1-year rule. So it can occur anytime before, but if Parkinsonism occurs, it has to occur within that year to be considered DLB. So that's the sine qua non essential criterion. We have two diagnostic criteria categories for DLB. One is probable, which is more stringent, and one is possible, which is less stringent. And so for probable DLB, one needs two or more of the core clinical features, which we'll go through in a minute, with or without indicative biomarkers, or one core clinical feature and one or more indicative biomarkers. The possible DLB, which is less stringent, we need only one core clinical feature, or alternatively, one or more indicative biomarkers. So you've already heard a lot about the clinical features we're going to talk about. One is fluctuating cognition with pronounced variation in attention. The second is the recurrent visual hallucinations, which, as you've already heard, are usually well-formed and detailed. REM sleep behavior disorder, which is new, and one or more spontaneous features of Parkinsonism, either rest tremor, rigidity, or bradykinesia. The indicative biomarkers, which can also serve to get you a diagnosis of probable DLB, include reduced basal ganglia dopamine transporter uptake on DAT, SPECT, or a PET scan, abnormal low uptake on 123 iodine MIBG, which is myocardial scintigraphy, which is not very commonly used in the United States, and then third, polysomnographic confirmation of REM sleep without atonia, which is the gold standard for diagnosing REM behavior disorder and is used when you need to confirm it. There are also several supportive clinical features as well as supportive biomarkers, which I think we won't talk about today. Next slide. So in terms of this gentleman, case one, he is a classic probable DLB, as I'm sure you've guessed by now. He had dementia by history, and so it's very important to ask about functional assessment. So he reported difficulty with bills, taking his medications, getting lost when driving. So I spend a lot of time on history, and as we'll talk more about, and getting these specific items written down. Sometimes there's a need for more formal neuropsychological testing, and I think that's very important when we're talking about people with subtle Parkinsonism. We want to get the neuropsychological testing to pin down that diagnosis. And there are specific domains which you've already heard about, including executive function, visuospatial function, less so memory, but executive function that can be brought out by the neuropsychological testing. So of course that can't be done at the initial television video event, but we often arrange for separate neuropsychological testing at a later date, and that can also all be done remotely. In terms of this gentleman, he also had clear evidence of Parkinsonism. He had the bradykinesia, he had the rest tremor. He also had visual hallucinations that were well formed, and by history from his wife, a history of REM behavior disorder, which you've already heard about as a core clinical feature since 2017. Again, it can't be done on video, but if you're not sure about the RBD, you can send to a sleep specialist for polysomnography. So by criteria, this gentleman had two core criteria that were needed for the diagnosis. And as I've already mentioned, remote examination may make detection of mild Parkinsonism difficulty. As you saw in the criteria, rigidity is one of the main features that we look for, and that obviously you cannot do on a remote exam, so we can't pick that up, nor can we pick up postural instability. So in the setting of people who come in who have cognitive impairment that's more prominent than the Parkinsonism, remote exam can be somewhat difficult, and I tend to bring people in that setting. Next slide. So making the diagnosis remotely, history is probably, just as an in-person exam, even more important. So we have to rely on good history remotely because there may be limitations on the examination. So we want to make sure that we get a good estimate of the cognitive impairment in Lewy body disease to aid in the diagnosis. And as you've already heard, you can see worse executive function, attention, and visual spatial function than in other domains. The memory impairment can occur early, but may occur later on after the executive function, attention, and visual spatial impairments. In terms of history of RBD, it may be a little bit more difficult to make that diagnosis in women who may have less dream and acting behaviors. And we also look for those supportive criteria. So this gentleman we talked about had constipation, he had dizziness when he woke up, or when he stood up, and he also had some hypersomnolence during the day. And then again, if you need more diagnostic biomarkers, we can do DAT scan or polysomnography, which are the indicative biomarkers. But again, that would be separate from the remote exam. Next slide. So in terms of our expert panel, about half of them, or a little bit over half, 57%, felt very comfortable making the diagnosis of LBD virtually. Somewhat fewer, about 43%, felt either very comfortable or comfortable with delivering the diagnosis virtually. And most felt very comfortable making a clear diagnosis of Parkinsonism when it was obvious, when it was moderate to severe. And understandably fewer, 29%, felt comfortable or very comfortable with determining trace or mild Parkinsonism, that being one of those situations where you might bring somebody in for an exam afterwards. Next slide, please. In terms of remote cognitive assessment in DLB, there really is no standardized approach yet, particularly remotely. There have been validation studies in Parkinson's disease, but none in dementia with Lewy bodies yet. Our expert survey, which I'll show you in a moment, indicated that aside from that, the Mocha Blind was the most utilized tool. As you've already heard from Katie, the Mocha Blind does not include visuospatial or executive function, which are obviously important components to obtain. You can also use a regular Mocha and either mail the information to people ahead of time or do it by holding it up and having an oral component to the regular Mocha. As you've heard, the Mocha Blind is on a score of 22 out of the 30. 30 is the regular Mocha, 22 is a Mocha Blind. If you score 18 or over, that's considered to be normal. You can also do a conversion from Mocha Blind to Mocha. So this gentleman would have had a score of 19, which is actually in the mild cognitive impairment range, but that's where your functional impairment comes in handy because again, Mocha, MMSE are screening exams. And so if you have a significant cognitive impairment with functional impairment, that would still qualify as a dementia. And that's another situation where sometimes if they're on the edge, you might get formal neuropsychological testing. For a regular Mocha, score of 26 or over out of the 30 is considered to be normal. And the Mocha asks you to, by definition, add a point for those with less than or equal to 12 years of education. And I think what I've been stressing is you do what you can remotely, but then you may have to supplement with neuropsychological testing or bringing people in for a more formal motor exam. Next slide. And this is just our expert panel again, showing you that Mocha Blind was the most widely used. CDR is a functional scale telephone interview for cognitive status is widely used and just on the telephone. Then we have MMSE, which again, I actually tend to favor. I use that. Neuropsychological battery less so, and the full Mocha, you can also, as I said, share the PDF. Next. In terms of the remote motor assessment, there have been multiple feasibility studies in Parkinson's patients, but none yet in DLB. Again, our recent survey among the experts indicated that aside from the typical neurological exam with supplements, the modified part 3 of the MDS-UPDRS, which excludes the assessment of rigidity or postural instability, was the most common. Next slide. And this is again just showing you that the most commonly used assessment from our expert panel was just the regular neurological exam and with components of the MDS, but after that, the modified MDS-UPDRS was used. Some people use a modified unified Parkinson's disease rating scale, which is an earlier version, which is more commonly used in the Alzheimer's Disease Research Center studies. And some people use the abnormal involuntary movement scale, which is most commonly used by psychiatrists to assess dyskinesias. Next. So how do we deliver the diagnosis virtually? Next slide. So I think, this is a major concern for most of us, especially since most of us or many of us have not been doing virtual examinations before the pandemic. And I think it's extremely challenging to develop a rapport with patients who you've never met and had no laying on of hands. So in our survey, again, understandably, 50% of the respondents had concern for delivery of the diagnosis, which some might perceive as bad news in the home setting versus in person. And some, 21%, indicated concern with the virtual encounter negatively impacting on the mental status of the person with LBD. because already they may have impairments and have difficulty with dealing with a remote exam, and then giving them news on top of it might be even more confusing. Next slide. So how do we handle delivery of diagnosis? Well, I think probably just as in an in-person setting, you want to have a sense of whether they have support people with them. And one of the tremendous advantages I've been pleasantly surprised by doing remote exams is that you can have multiple support people who may not be geographically located in the same place. So this really gives an entire family or family and friends or caregivers an opportunity to hear a diagnosis and ask their questions at the same time. You can also assure people that if there's more workup needed, if they need to come in for their motor exam or in person, or more neuropsychological testing in person, that would be done at a later time. Just again, as in an in-person setting, you want to assess whether people are ready to hear the diagnosis and kind of frame that. I can give you the information that I've gathered. Are you ready to hear what I'm going to say? And make sure that they are ready to hear it and that their families are poised. Empathy is a sine qua non for any encounter with a patient. And again, I think it's difficult to establish that empathy with people remotely, but you do have the opportunity to sit and listen, and you're actually seeing people in their home environment, which I think helps a lot in trying to engage in understanding of what they're going through. And I think, again, as in an in-person setting, I always try, and I think most of us do, to try to accentuate the positive and what the patient can do. You're giving them a diagnosis of a disease which currently there are no disease-modifying therapies for, so you want to stress what they can do to make a difference. And I spend a lot of time, as do I think many other specialists, talking about the importance of reducing cardiovascular risk factors with, for example, Mediterranean diet and exercise, which again has been shown in Parkinson's disease and in some studies in Alzheimer's disease as important. And of course, exercise is important in fall reduction. So many of these things can lead to quality of life improvements. And then the other advantage we have with using a remote visit is that we can give much more information in an immediate sense in the aftercare statements, information on education and support groups. So there are certain advantages from the remote exam that we're learning more about every day. Next slide. I'll pass it on to Dr. Fleischer.
Thank you, Karen. And yep, I'll just, for this, that was excellent. Thanks, Karen, Dr. Martyr. So we'll get started with the second part of the case. And so of our discussion today with our second case. And this portion of our talk today will be addressing technology challenges and limitations. Next slide. So this was a patient that was seen in follow-up with a diagnosis of probable DLB as made by the criteria that Dr. Martyr talked about. But basically, just to summarize, he has about 4 years of cognitive impairment characterized by visual spatial disorientation, executive dysfunction, impairment in attention, and delayed recall. Around this time was when he also developed Parkinsonism, as well as spontaneous rare hallucinosis. It did impact his function, driving, finances, managing appointments. And the most recent in-office Mocha score was an 18 out of 30. So I was seeing him in follow-up, and there was a couple issues that I'm hoping Dr. Fleischer will talk about, where first it was hard to get the camera angled on him. He was accompanied by his wife and daughter. They tried to help as best we could. It did challenge the exam a little bit, but we were able to do, what we could, see what I could. The patient really enjoyed, he made a comment of saying, "This is great. I love how I didn't have to come to the office." And so he was pleased with the at-home visit and wanted to do this from here on out. And so they were happy about that. The visit from his perspective, from the patient's perspective, went well. He really denied any complaints. He felt like things were going well. But like I said, it was hard to really, see him and connect with him as I would have liked. At the end of the visit, while, he said everything's going well, his wife kind of chimed in and was a little upset that she felt like his perspective of things weren't what she was thinking. She had concerns about him really seeming like he just doesn't want to do anything. She wants to go for walks with him. She wants to enjoy their time together. And she just says he just seems to not want to do anything. And you could feel a little bit of this stress coming through. And so now I'll hand the slides over to Dr. Flesher. Again, we're so happy to have you. And if you could talk us a little bit through how you maybe address these challenges.
Absolutely. Thank you so much, Dr. Amadeo. And speaking of, traffic getting to and from being one of the benefits of being able to do video visits, apologies if you are hearing the Chicago L outside of my window. So I think these are some really, really common situations and issues, the satisfaction with not having to travel and being able to do things from home, but also sometimes this discrepancy of the patient says one thing, their care partner says something else, which is not limited to a telemedicine visit. I think all of us have probably experienced this in a regular office visit as well. But if we can go to the next slide, we can see back in June when the survey was conducted, the experts were asked, what were some advantages of the remote visit? And I think it speaks to this, which is 100% of the 14 experts felt that telemedicine visits, remote visits addressed travel and mobility limitations, and similarly allowed us to provide care during times of pandemics or natural disasters, and allowed for evaluation of urgent issues outside of the emergency department, which particularly in this last year, keeping our patients out of the emergency department when they don't need necessarily that level of care is even more paramount than it is sort of during normal times. 14% of people, of the experts, felt that it was easier for family members who live remotely from the patient to join that encounter. And I wanted to point that out for a second. I think that 14% is a low number, and there could be lots of explanations for that. Again, this is a small number in this study. 14% is 2 experts here, but keep in mind that the survey was sent out in June of 2020, and I think we've learned a lot since then, and you may have experienced this too, is that wherever you are, if you're using telemedicine, your platform may have changed. You may have streamlined your approach. You may have figured out ways to bring other families in, family members, other care partners in. And similarly, provides insight into the patient's home environment. Only 7% of people, or 1 person, said yes to that. Full disclosure, you might be speaking to that person who said yes to that. And so I think, reflecting on that, it would be really interesting to redo that survey now and with a broader audience to see if people have adapted their practices to really be able to look at the home environment more. Next slide. So what are some of the disadvantages? Well, 93% of experts cited technology failures. 79% said that there is a lack of familiarity with the applications or the platforms among their patients or their care partners. And so some of the time for each of those remote visits is taken up with just trying to get the person online, get them on camera, get them situated, make them comfortable. 86% of the experts found that the inability to perform a complete physical examination was a notable challenge, and half expressed concern about delivering a diagnosis in this setting or delivering bad news in the home versus being able to do that in person, which Dr. Martyr discussed. 21% indicated concern that the virtual encounter could negatively impact the mental status of the person with Lewy body dementia, either in real time or perhaps concerns after the fact, that there might be some confusion or some disorientation or misinterpretation of what went on during that visit. And we'll talk about that in a bit and how to try to troubleshoot that or head it off at the pass. Next slide, please. So, what are some challenges in this population in general? In a recent study published in 2020, it was found that only 55% of older adults own a smartphone or have internet access, and only 60% are able to find a website or send an email. So this ability to navigate computers, to use the internet, what's often referred to as digital literacy, is a really growing area of study, even in the before times, before the pandemic, particularly digital literacy among older adults. And there are actually a lot of scales and assessments out there to try to measure different aspects of this. And although evidence suggests that the pandemic has absolutely, exponentially increased the uptake and the use of telemedicine among older adults, there was a digital divide before the pandemic, long before COVID-19, such that lower socioeconomic status, older age, Black race, Hispanic ethnicity were all independently associated with being less likely to access the internet, less likely to continue use once they had access that was initially gained. And so if those populations sound familiar, it's because the populations that are at highest risk of COVID and arguably most in need of being connected to care and maintaining that connection to care via telemedicine may also be the hardest to reach. And so addressing those challenges is certainly beyond the scope of this talk today, but of urgent importance. And stay tuned to the literature because I know there's much going on there. Next slide, please. So how do we try to overcome some of these challenges and limitations? I think there are a lot of things that we can do pre-visit, setting up in terms of choosing a platform that is easy to use. And that kind of assumes that your institution or your practice hasn't already chosen for you. If they've chosen for you, you may not have much choice. But if you do have some flexibility or are making that decision, make sure to test not only what do you see as the provider, but what does it look like from the patient and care partner side? Because sometimes there are some that are very easy to use for one member of that treatment dyad and not of the other. So highly encourage you to download your own institution's portal and see how it goes as a patient if you can. As the provider, doing practice runs can be incredibly helpful, but also encouraging patients and care partners to do practice runs on their own. They can't necessarily run a visit, but if someone is really new to telemedicine or you're concerned about their digital literacy, their ability to do this, I encourage people download FaceTime, download WhatsApp, get some app where they can practice just being on camera, seeing themselves in that picture-in-picture and format. Call the kids, call the grandkids, call a neighbor, call someone, not only to get comfortable with using this, but also with, okay, mom, we can't see you, or, the light is blocking you, or you need to move the camera away. We're only looking up your nose. These are the things that can really delay a visit, can be really frustrating to patients and care partners during a telemedicine visit. And if you can, deal with those ahead of time, everything goes smoother for everyone involved. So as much as possible, having staff check people in prior to the visit is critical. So I see someone just put into the panel, having medical assistants call, absolutely. We are certainly fortunate here to have fabulous medical assistants who are our experts in helping people get connected to the platform, but having them run through not just reconciling medications and allergies, but make sure that the audio and video are working and taking those steps to troubleshoot those. If you can get your medical assistants or your staff connected with the IT folks on a regular basis, that also really helps. If possible, depending on the living situation of the person and vaccination status, having a tech-savvy family member present for the visit is really helpful. One thing to know is to ask really clearly who is there in the room with you. I had a recent visit where a patient kept saying, oh, my daughter is on the laptop. My daughter is on the laptop. No one was adjusting the camera and it was focused down at the ground. And I thought, what is this daughter doing? She is pretty useless. And she meant that her daughter, who was also remote, was using Zoom to watch the visit from her own home, but on a laptop on the counter. So if you're lucky, having someone there who is fairly tech savvy and can help, can adjust the camera so it takes one less thing off of the patient to worry about. Next slide, please. One great thing you can do is send instructions ahead of time. So as an example here, Dr. Amadeo's instructions, they hit a few key things. Log on early, something is going to go wrong. Log on early so there's time if things are working. Try to advise people to sit close to their internet connection or router so that they have the strongest signal. If they don't know where that is, give them time to figure out where in their house is the strongest signal. That being said, don't sit too close to the camera. You don't want to see just here, but sitting at least 6 to 8 feet away and having room behind them where they can move, where they can stand up, where they can walk. If that's at all possible, that will be really helpful. A really important thing is to try to avoid a dark silhouette and kind of funny shadowing. Is ideally you want the person's sitting with light hitting them, not light behind them. They will get a really funny shadow. Not only will they be hard for you to see, but given the visuospatial processing issues that people with Lewy body dementia can have, their own picture-in-picture version of themselves, especially if it's someone who's not used to this format, seeing their own image but distorted and shadowed funny can be really confusing. So light in front of the patient, behind the camera. Some additional helpful preparation things that I often recommend is, as cute as they are and as much as we would love to see everyone's pets, trying to keep the pets out of the room makes the visit smoother and quieter. Asking them to not be next to the subway or turn off TVs, radios, loud heating or air conditioning units. Not only do these make it harder for you to hear the patient and for the patient to concentrate, which seems obvious, but one of the things that I think people don't necessarily realize about telemedicine is that even in this moment, our connection is dependent on the upload and the download speeds. And there are pixels of information going back and forth, both audio and video. And any background noise is going to be something else that has to go through that bandwidth. So any excess noise that you can take out will make it a better connection. Similarly, this seems like a nothing, but if you are having a hard time with a connection, if it's particularly spotty and the patient has a ceiling fan on, have them turn the ceiling fan off. Not only does it have a tiny little bit of buzz in the background sound-wise, but the video component of sort of shifting shadows all the time can be very confusing for them to see on that picture-in-picture, and is also another source of constant pixels going back and forth. And yes, eyeglasses, hearing aids, any sensory devices, any assistive devices that people need, that they would be bringing with them to the office, they should be using during their visit with you from their own home. Next slide, please. If you can, setting expectations can go a really long way to alleviating that visit-related anxiety that people can have, whether it's in office or telemedicine visits. So if you can send a symptom checklist ahead of time, this way, if it's possible to upload it to your patient portal, amazing. If not, if people just have it printed out or up on another screen separately, not toggling back and forth, they can tell you which symptoms are most important to them. They'll know what kind of questions you might be asking of them, and it alleviates some of that anxiety about what exactly is going to happen here. So I highly recommend this checklist that's available from the LBDA. Next slide, please. So I think during the visit, a couple of things are really important. So introducing not just the visit, not here's what we're going to be doing today, but reintroduce yourself, even to the patient that you've known for 5-10 years. The patient doesn't have the usual visual cues and the usual preparation of driving to the office, going into the hospital, checking in with your staff in the same way. It can be very, very disorienting to suddenly see you in a different context on the screen. It's the same as when we were kids and we saw our teacher at the grocery store. It's just a little bit discombobulating for a moment. So I always reintroduce myself. Also ask if they can see you okay. You know that you can see typically your little picture-in-picture, but it may be a very different view that they see on their screen compared to what you see. So make sure that they're not just looking up your nostrils. I also, especially after the first month or so of the pandemic, started to realize that there was a lot more delusions, a lot more anxiety going on in patients. And some of the paranoia that can be part of Lewy body dementia seemed to be kind of attaching itself to the telemedicine. And so I think it's really critical to state outright that we are here in real time. This visit is not being recorded. We're having this visit today, just like we would be in the office, to see how you're doing, see if we need to adjust anything. We're just here to help. And when you click leave meeting, when you click leave the visit, that's it. Another thing is to really, if possible, if your institution will allow it, avoid a virtual background. I think we've all at this point been on Zoom calls or WebExes where someone has a funny virtual background and an arm or an appendage is sort of coming in and out of that green screen and virtual background. It can be a little bit strange watching that in any meeting. It can be very, very disconcerting to someone who has Lewy body dementia, who has visual spatial processing issues. That can be a distraction. So if if you can make that go away, let them see your messy office, I found that that is far less distracting. Next slide, please. So clarifying the roles, expectations, how the encounter will be organized. I usually just give sort of the shot of, I'm going to start by hearing from you. And then if it's okay, I'm going to turn to your spouse, your partner, your loved one, your daughter for additional questions so that there's sort of an idea of how the show is going to run. And it lets the care partners know that you are intending to hear from them. They will have time and space to be able to have, share concerns. If it's possible, sometimes where it's clear that something is going on that the patient is not admitting to, but the care partner is worried about, if the care partner is able to take, especially if it's a tablet or if it's a smartphone, if they can take it into another room after we've completed the history and the physical with the patient and say, here's what I'm really concerned about, here's what's going on that I didn't feel comfortable saying in front of her or him, that can be really helpful. Sometimes time simply doesn't allow, and so we may need a separate follow-up call with the care partner to ensure that they feel supported. Next slide, please. So a lot of this, I had the opportunity to put this all together into a video for patients, and so you can check out this Lewy brief video on the LBDA website. And along with that, next slide, there's an accompanying tip sheet that covers a lot of these same things. So feel free to share that with patients if that's helpful, with care partners if that's helpful. Next slide, please. So always have a backup plan. Even if your platform, if your connection is perfect, if they've turned off all of their sounds and everything, there are several visits a week where the sound is not working. There's a terrible echo. I can see them, but they can't see me. Have a backup plan that at least you're going to go to if the connection is lost. That might just mean calling from your mobile phone, blocking your number potentially. That might mean calling from your office phone, or there are apps like Doximity, Dialer, Google Voice, things where you can use a phone and attach a different number to it so it doesn't get blocked on the person's caller ID, but at least you can continue and sort of have a phone visit with them. I think, as Dr. Amadeo mentioned, one of the benefits to having telemedicine visits is you can say, all right, you know what, I'm going to, grab for you this website that I think would be helpful. I'm going to put together a packet of information and I'm just going to send it out to you in the portal if you're able to do that. So putting, a very health literacy friendly lay language summary of here is what you're going to do. Here are the recommendations. I'm going to send this to you in your portal. You should see this, in 5 minutes, or I'm not going to get to it until tonight. This will be, in your inbox tomorrow morning. And you can send all kinds of helpful resources, links to LBDA and other sources of great information. And again, if there are things that are being missed, inevitably there will be visits where there are things that are missed and unclear. Arranging for an in-person follow-up, especially now that we are moving forward with vaccines, that becomes more possible. Next slide, please. So in conclusion, I think the call for telemedicine during the pandemic has been very clear, but certainly seems to have a role going forward. And there are clear advantages and some limitations. Dr. Amadeo, do you want to?
Thank you. Sure. Thank you so much, Dr. Fletcher. That was excellent. And I think you highlighted a lot of helpful information for our attendees. But yeah, so like you were saying, we are in need for validation studies to make new standards in making the diagnosis for Lewy body virtually. But important things to help optimize our setting expectations, pre and post communication, I think, are key. So thank you all. Thank you so much to our speakers today. We have just a little bit of time for some questions. And everybody's asked really good questions. So I'm going to try to get to some, but like I said, we will be following up with answers via email if we don't get to yours. I have one question that I thought we could hopefully get to that I'm going to actually pose to Dr. Jennifer Goldman as one of our experts. So the group brought up an excellent question. We talk about the 1-year rule, but no two patients are alike, and we talk and there's patients that maybe they don't quite meet criteria for dementia, but there's cognitive impairment early on. They seem to be meeting other core features. How do you approach this when you're thinking about diagnosis?
Sure. Well, thank you. And what a great seminar so far. Delighted to be here. So I think, the 1-year rule has been in the literature for quite some time and has enabled people to help categorize patients for diagnoses and for clinical trials and for care and prognosis and recommendations. But I think we always have to think of things in a context. I know in the field, there are definitely people who are lumpers and splitters. And this has been often a source of debate or fun debate amongst people in the field. But I think just to also bring this home into the conversation of telehealth and using it from a diagnostic standpoint, we want to be able to establish the chronology as best as we can to help render a diagnosis. And so really trying to tease out the chronology of the cognitive or behavioral symptoms related to the motor symptoms and so forth, as well as responses to medications and sensitivities, which of course may play a different role in treatments. So I think it's a little bit of a conundrum still in the field and a hot debate, but being able to identify those key features, even using the checklists, can be really helpful.
Thank
and
you.
can be done via telehealth.
Yeah. Thank you so much. I'm going to pose a question to Dr. Flesher. How are you have you found any possibility of incorporating other people in your visit, such as a palliative care provider? Or how do you approach that when you feel they need somebody else there?
Absolutely. So, I mean, it's a great question. And we've been really lucky pre-pandemic, since 2014, we've been doing home visits. And so I've had the opportunity to sort of go to the home and have an idea before the pandemic hit of what can we do in the home, and then pulling back and having a nurse, a social worker be present to think about what kind of resources do patients need who might be homebound or might be sort of approaching a homebound state, and what actually exists and is out there, because I don't think that we get a lot of training in that typically in med school and in residency about, area agencies on aging and who could be pulled in. So I think there are a tremendous number of resources and a lot that have come about through the pandemic. And certainly in our clinic, we've been able to incorporate a neuropalliative care physician. I know other places have palliative boarded physicians who can sort of tag team in. There are a lot of different models to bring in palliative care, to bring in social work. And so sometimes we have videos where we have 2 or 3 providers all sort of doing a group visit with the patient on a tablet, with their care partner or another loved one in the home. Sometimes we will do tag team visits where one of the providers starts, then we hand off to the next person. So I think there are a lot of really creative ways to see telemedicine not as a limitation to interdisciplinary care, but as a facilitator. It just requires a little bit of creativity and flexibility.
Well, thank you so much. I think for the rest of the questions, we will hold those and provide them in a follow-up email. There were some really great questions and we'll certainly get to them. If you feel like it's not answered, please feel free to email us. I'm going to hand over to Miriam Giles, who did so much to organize this, and thank you so much.
Well, thank you all very much for joining us, and thank you to our panelists and to our presenters. Just a brief reminder that we do have some more materials that are coming to you in an email from me, Miriam Giles. It's going to be mgiles@lbda.org. You'll receive an email from me about how to evaluate the activity today, and also if you are interested in getting CME credit or getting any kind of credit for attendance, you'll be able to do that as well. Also, a reminder that we do have 2 more webinars that are coming up in this series. The next one is on the 8th of April, and that is also on our website. And then one after that is going to be on May 27th. So please do visit our website for more information there. And thank you all for taking your time and for sharing your afternoon with us. And we hope you have a great evening.
Thank you.